Good morning. We're going to start the session number 6, which is evolving concepts in adjuvant therapy in prostate, bladder, kidney case-based debates. I'm going to actually moderate this with Will Marsh and with Rob. The way it's going to work is we're going to have a case-based discussion. So Rob will start by presenting one case, and I'm going to ask Dr. Gomella, Herchenhorn, Sandler, Cora, and Wygoda just to get on the panel and address the case. Rob? So we'll start with a Mr. R, who is a 66-year-old gentleman. He presented with urinary incontinence, suprapubic pain. He had actually a colonoscopy that was normal, and he's referred with a kind of diagnosis of Gleason 10 T4 disease and a PSA of 3.7. The brother was diagnosed with low-grade prostate cancer. He has been followed by active surveillance. And I'll show you the CT, which shows a thickened bladder, no Mets. Bone scan is negative. Noteworthy, there is clearly bilateral hydronephrosis. And there's also a possibility of rectal wall involvement on MRI. So may I ask maybe just to comment, just to start with, PSA 3.7, T4 or T3 disease, Gleason 10? Does that sound right, or any comment at that stage with bilateral hydro? Cora?
Hello, can you hear me? Hi, Cora Sternberg. This is a prostate cancer case. That's right. This is a patient with a.
It's a bladder case, actually.
Gleason 10. What?
Yeah, no. That's the beginning of the bladder case, of course. No, I get it. So I'm trying to tell you that I'm starting the bladder cancer case with a gentleman with that type of disease who is referred with a diagnosis initially of Gleason 10 prostate cancer and a low PSA and bilateral hydronephrosis. I'll leave the surprise in a couple of minutes, okay, of course. But I just want to have any comment.
We have a patient with a Gleason 10 T4 disease of the prostate.
Yeah, that's a referral
okay.
Indication.
Forget his brother, okay? And then you see a thickened bladder with no Mets.
Yeah.
And he has bilateral hydronephrosis. So you're going to do a cystoscopy?
Yeah. So the DRE shows bilateral disease, extraprostatic probably. And he's actually, when he's referred, started on Zoladex and Casodex. So you want to have a cystoscopy, anything else?
Cystoscopy and biopsy if you think it's also bladder case. We're not just treating prostate cancer here, right?
Well, I don't know. Yeah, for sure.
Okay, TURB and putting in bilateral stents, probably he's got hydronephrosis for the bladder.
Okay. Set?
Reasonable set?
So what's his renal function, Alex?
Kidney impairment, I don't, on top of my head I can't tell you, but very clearly over 200 when he presents.
So if he's got any compromise of his renal function, then you need to decompress the upper urinary tract.
Yeah.
We usually would start with trying to do that from below cystoscopically. And with a T4 tumor, you may get encroachment. Well, presumably you've got encroachment of the bladder neck and trigone. And so the other option would be, if you can't do it from below, do it from above. And while you're initiating hormone therapy with presumably initially combined androgen blockade. Alex, do you want to get the rest of the bladder panel up here because it's slightly different from the prostate?
Yeah, for sure.
So is Avi here? I think Avi Selov is on the panel.
There's Avi
and Shirok
Shariat,
are you here?
and Raman.
Okay, I think we got enough experts
Yeah,
up here that
for
can
sure.
manage this.
I have a question to you.
Yeah.
In a situation like this, when you have a high glycerin and low PSA, how was the prostate cancer diagnosed? Did they do PSA, PA staining? Because in a situation like this, we always have to think about polydifferentiated cancer that can be either bladder or prostate. So how was the diagnosis done?
It was diagnosed on prostate biopsies, and I think that's a very good comment. I was trying to say that indeed when you have disease which is completely undifferentiated.
Did they do PSA and PAP staining on that specimen, do you know?
They didn't, but I'll show you, and it's, again, very, very good point. That's what we did. So that's actually the CT that kind of surprisingly doesn't show anything in the upper abdomen. You don't have the kidneys, but that's more for the retroperitoneum. That's the aspect of the bladder. And that's the CT. Set any comment?
What's his PSA?
3.7.
Sorry?
3.7.
So how sure are you of the clinical pathologic diagnosis of prostate cancer?
Exactly. We're not at all. So basically, especially when we get patients who are referred and where there's a completely undifferentiated prostate cancer, there's complete disconnect. And the topic here was bladder cancer involving and infiltrating the prostate. That was one of the subtopic of today's. This is exactly what happened. So we reviewed the pathology. There was indeed a Gleason 6 prostate cancer. But actually, although there was tumor going into the fat with extraprostatic extension, when we looked with the different markers, and Theo Vannequist did that, actually it was a completely aggressive bladder cancer and not a prostate cancer. Some Gleason 6 for sure. And so the diagnosis at the end of the day was not Gleason 10 prostate cancer, but high-grade urothelial carcinoma in the biopsies infiltrating the periprostatic fat. So I get back now. So you know you're dealing with high-grade bladder cancer and not prostate, and this is the CT. There is no obvious MET. There is hydronephrosis, so the patient will actually get nephrostomies. We're on the same page. I'll show you later on. But any other comment about the management? How would you manage and treat?
So one thing also that we're doing a bit more of in these locally advanced cancers where either CT, well, typically if you've got some suspicion on CT, say of adenopathy, then if it's going to change management, we'd get a PET CT to try to adjudicate whether or not there's a higher likelihood of clinically node positive, because as I suspect Cora might discuss, the length, the number of cycles of upfront chemotherapy would be different in a patient who's clinically N positive as opposed to clinically N negative. A T4 tumor like this, presumably it's mobile by manual, Alex?
Yeah. Yes, I would say a small yes.
Okay, so then a T4A tumor with direct involvement of the prostatic stroma, that patient has probably at least a 40% probability of occult nodal disease, and so there'd be an imperative for neoadjuvant chemotherapy. But that discussion then depends on what happens with his renal function if it gets into a range where they could get cisplatin-based chemotherapy, but I'd ask for Cora's advice on that.
So that's the nephrostomy. We started GEMSIS for 4 cycles. Any comment, Cora, about how you would manage the locally advanced infiltrating the prostate up to beyond the prostate, so into the fat?
I agree completely with Seth about make sure your staging is good and understanding whether or not there's lymph nodes. Unfortunately, many Americans, I know, do not do that. And there were 2 papers back-to-back using the regime that we actually developed in the RTC on high-dose MVAC given as neoadjuvant therapy. And I wrote a commentary on it that I was very upset that they were using 4 cycles because there were patients with lymph node positive disease and they were giving 4 cycles, which I think is inadequate if you're clear that the patients have lymph nodes. That's not in my mind, pure neoadjuvant. That's a patient that already has metastatic disease. But these were just in the JCO like last month. These two papers from MD Anderson and from the Fox Chase, and some of them were the Fox Chase was a multi-center study. So they were using 4 cycles of high-dose MVAC. And I think that 4 cycles of GC is adequate if there's no lymph nodes.
Now, it was well tolerated. Creatinine was 131. He presented with a PE. We see more and more, and there's more and more reports about DVTs, PEs, clinical, and I've seen patients actually, honestly, with massive PE, with neoadjuvant before cystectomy to the point that they were oxygen bound, wheelchair bound. So how do you manage, and on top of that, do you systematically now give some type of prevention of in these patients, large masses and undergoing chemotherapy?
We do not prophylactically give heparin to patients who are undergoing chemotherapy. If patients are up and mobile, we do not do that. We do that only in patients who are bedridden.
So he was placed on blood thinners, and
a patient on blood thinners, I would be very worried about giving gemcitabine and at all, because gemcitabine is known to lower the platelet count in a serious way.
Yeah, for sure.
But
actually, he kept his platelet count fairly reasonably normal.
I just want to make a comment about the choice of chemotherapy. So this patient got 4 cycles of GC.
Yeah.
Yeah.
So that's not evidence-based. So as you know, I mean, I have this question about how did GC get adopted in this specific setting where it's neoadjuvant chemotherapy, where there's no clinical evidence of node metastatic disease, because both the international trial and the SWOG trial used MVAC. And I understand the rationale for using GC, but just to remind the audience that the data, the level 1 evidence really are there supporting MVAC. There'll be a clinical trial that's going to be starting very soon in North America. It's a randomized phase 2 of dose-dense MVAC versus GC. Specifically in this setting, it's asking a biomarker question about whether coxin can predict response. So we'll get a little bit of a readout on the comparative efficacy, though that's not the primary endpoint of the trial. So I would still really push the medical oncology community when it's feasible to use MVAC in this setting. That's just sort of my claim.
Just to actually go somehow against that is that this is the CT after the 4 cycles. So I remind the entire story, presenting with refer for prostate cancer, Gleason 10, T4 disease, hydronephrosis, placement of nephrostomies, review of pathology, ending up with a Gleason 6, but a very high-grade aggressive bladder cancer. GemCis 4 cycle, you remember the CT showing the infiltration of the rectal wall. That's a CT now, so comments and management. How do you, and there's no sign of nodal disease. We didn't do a PET scan, but there's absolutely no sign whatsoever of no disease in the upper abdomen. CT chest is negative and bone scan is negative.
So it looks like there's still a residual disease. So this is a patient that we would take back to the operating room, do an exam under anesthesia to make sure that you can do a cystectomy and remove everything completely. And then because of the T4 nature of the disease, we would generally try to steer the patient away from a neobladder, and potentially have to give some consideration to a urethrectomy, though I wouldn't do that en bloc, because I think this patient's biggest risk is of both local, regional, and systemic failure. So if all that adds up to going ahead with a cystectomy, that would be, and then in the context outside of a clinical trial, we would do an extended node dissection, at least up to the aortic bifurcation. One little caveat is that if you get in there and you have to make sure that that everything's resectable. So sometimes you get fooled on the EUA, and There's always the potential for direct extension, either the pelvic sidewall, the symphysis pubis, and then really taking a good look at the nodes, the periureteral tissue, to make sure that that patient actually is going to derive a benefit from cystectomy.
Would you take part of the rectum? Here's Shirok joining. Would you take part of the rectum
So,
at
that's
the
a
time
really,
of surgery?
yeah, that's a really good question, Alex,
Because
I know
basically I can tell you that this patient who was part of our weekly multidisciplinary bladder cancer clinic, where all our patients are discussed by ourselves and the radoncs and the medoncs. We were so surprised that the DRE became kind of close to unremarkable. It was truly a dramatic change after 4 cycles of GemCis. So basically, do you plan to remove the rectum, or do you plan to see?
Yeah, that's a really interesting question, and so I think that an approach is to always anticipate the local regional extent of your surgery based upon the pre-chemotherapy findings, and so I would certainly be prepared to do that if everything else anatomically was resectable, and I would have the patient counseled about the potential for removing part of the rectum and having, the ability to do primary anastomosis. But I think if the extent of the disease intraoperatively supported not doing that, that would be fine. So you have to go in with all of your ammunition available to you.
Now, does the panel see another possibility of therapy? So we're at the level of consolidation. There's no hydronephrosis anymore, actually. I don't show you on the pictures. So is there any other way than surgery to consolidate, or at least to discuss consolidation in these patients?
You're talking about radiation therapy?
Yeah, or others.
I think this patient is not candidate for bladder preservation. So if you're going for curative intent, then radiation is not the primary choice, in my view.
Okay. Does everyone share that view? And my second concern is that when you have such a nasty disease to start with, which is massively infiltrating the rectum, which sometimes, and I fully agree with Seth, that you are underestimating. Sometimes you have this tumor that goes truly around the rectum. How sure are you that even surgically you will be able to achieve negative margins?
Well, you want to give Shirok a chance? Do you want to
say something?
Thank you very much. Sorry for being too late.
So, Shirok, refer for Gleason 10 prostate cancer, rectal involved by a tumor going beyond the prostate, was reviewed. It's a high grade. He had bilateral nephrostomies, got GemCis, the tumor completely melted, and that's where you stand now.
Yeah, I think your point is very important, and what Seth Lerner has said, the only chance this patient has for having an improved local symptoms improvement, or not having a local progression, having problems from it, and from long-term survival, maybe a benefit, is a total extirpation of the tumor, and achieving negative margins is at the heart of that matter. So how are you going to ensure that? You're going to take a wide excision, and as Seth Lerner said, you have to be prepared to maybe take a part of the rectum or entire part and do primary anastomosis, and if you think it's too wide, you could do a diversion there and a lobulostomy or something, and then repair it. I think achieving negative margins, you try it all the time. Sometimes it's very difficult with some types of variant histologies, like plasmacytoid variant and so on. So you're not really sure where you are, and you cannot send margins, but you surely will attempt it maximally in this patient. And sometimes you have to carve on the bone, and sometimes you have to go locally extensive as far as you can, and just go on the vessels. And I think one approach is really go on your vital organs and go along your vital organs and preserve what is possible, and the rest just take it all out.
So just for sake of time, as we have also the prostate and the kidney cases, basically the patient was discussed as all patients in our multidisciplinary clinic, and we had a long discussion even with our colleagues from radiation oncology, and everybody felt that based on our experience, radiation would actually be one of the possibilities as a consolidation. He didn't receive concomitant cysts just at one point because of his renal function. Got radiation therapy. We usually even use lipiodol in addition to actually locate whatever is left of the tumor in the bladder. And believe it or not, the cystoscopy became normal. The cytology was normal. The DRE was completely benign feeling. And that was actually the follow-up. And even as of today, so we're now exactly 6 years later on, the patient is free of disease, no recurrence. So the point is, by no means, I'm a surgeon as well, but by no means I just want to show that in teams who are regularly seeing patients and where the two options and where the radoncs and the surgeons are equally on top of their game, these type of patients are not necessarily not candidates for radiation. He had a full discussion. We spoke. We had exactly the same kind of comment. We can take it. We can take some part of the rectum most likely. We will be fighting for surgical margins. And he opted actually after full consent for radiation. So any comment to wrap up and have Rob presenting his case?
Keep following this guy because obviously remains at risk for developing I guess what would amount to a second primary tumor of his bladder and or prostate. And so it just really, this is really a wonderful example of, as Alex, you pointed out, multidisciplinary team management. But the urologist has an imperative to stay fully locked and loaded and engaged throughout not only the patient's treatment, but the long-term follow-up. This really ends up in our sort of house, so to speak. And while this is a fantastic result, it's really remarkable, needs to continue to be followed pretty carefully.
He has been followed. I think the key point and the summary was just don't accept something that doesn't sound right. Even if someone is sent for Gleason 10 prostate cancer, treat it with hormonal therapy. Just challenge that, treat him, and even if you think that, you know, the only solution is cystectomy, there are other solutions on board as long as you have the teams to deal with them. That was truly the comment for this locally. So thanks so much to the panel. Let me ask Rob to move on to the prostate cancer case. Thank you.